All right, guys, so we will be going over prenatal diagnosis methods in this lecture. So let's start off in terms of, prenatal diagnosis. So these are procedures and tests that are carried out to diagnose genetic abnormalities, in addition to structural anomalies. Often, again, they do this at an early stage of an embryo or early stage of a fetus. So it provides ample time to undertake timely prenatal counseling and appropriate interventions. Um, and unfortunately, one of the options that this may allow for families to elect is would be the early termination of a pregnancy. So this is something that everybody needs to consider, and there's no right or wrong answer. It's personal. It goes from it's based on how a couple feels, and this is going to vary from couple to couple. And again, as I said before, there's no right or no wrong answer about this. So another thing that I want to mention is the difference between a fetus and an embryo. A lot of people they mix these two up. So um, up until the point of the 10th week, okay, the for now, let's say, okay, a woman gets pregnant, right? So she has a baby inside of her, right? So this term baby, it's not accurate, okay? It's inaccurate. So the terms that we use would be embryo and fetus. Up until the point of about 10 weeks, we would call that baby an embryo, okay? This is the correct medical term. From the 11th week on, okay, so again, starting the 11th week and then up until birth, the term is fetus, okay? So 11 week till birth, till the time right before birth, then we call that a fetus. And after the baby is born and once out of the mother, we don't call it a fetus anymore. You can call it a baby, but again, there's different terms for that. It's a neonate. That's the term, means a newborn neonate. And then again, as that neonate ages, the terms change again. So that is the difference between a fetus and an embryo. Now, in terms of, as we said before, in the last slide, one of the purposes for prenatal diagnosis is to come up with, is to provide an opportunity to have timely medical treatment, okay, for some condition that may be present to that fetus or embryo, either again, so before birth or even for after birth, okay, after the fetus is born. Again, certain steps could be taken to correct any issues that may be present with that, baby, because now we're saying, after birth. So again, these are decisions that parents need to make. So parents are to make this decision, in regards to whether to keep the baby or to abort that fetus, okay, based upon whatever the diagnosed condition is. And also, again, prenatal diagnosis, it'll give parents time to prepare psychologically, socially, financially, and medically, if they decide to proceed with the pregnancy. So it'll give them time to deal with the health problems that that they're going to be facing in that baby that they decided to keep. So the health problem or again disability that baby will have. And also, again, this is going to end up determining the outcome of the pregnancy as well. A lot of times, if the couple decide to keep that pregnancy, they have to understand that, all right, this is what the tests are indicative of. And, this risk carries along, a higher risk of spontaneous abortion as well. So again, it gives time, it'll give time for the parents to be well informed in regards to the decisions that they make. Now, what are some of the indications for prenatal diagnosis? So amongst the most The biggest thing is the advanced maternal age. So again, older women, essentially this is it. Uh, Now, when we say older women, what are we talking about? So, generally speaking, these risks they increase over the age of 40. They go very high after age 40. However, however, after 34, after 35, yeah, age about 35, the risks they do start to. Once you hit 30s, the risk levels start to go up. So again, this is another reason why it's again I advocate, and again if you go talk to um, healthcare professionals, the gynecologists, they will generally agree that it's best to have a child early during your youth in your 20s. This is an ideal time to get pregnant and have children. Now the other thing um, would that's which may be indicative for a prenatal diagnosis would be history. So perhaps there is a previous child with some type of a chromosome abnormality that's present, or women who have previously had a miscarriage, or again women who are pregnant with multiple, so I don't know, maybe two or three or whatever, however many number of children. So then they need to get diagnosis as well. Or if you have a family history of a single gene disorder, it's another cause for it. If there's a family history for neural tube defects, this is another reason for it. And again, if there is a family history of any other congenital structural abnormalities, and other times, if perhaps during an ultrasound or routine ultrasound, abnormalities may be identified, then you start to do more further testing. Now, other risk factors that may be associated with it, perhaps maternal illness. If the mother is sick, she has any other comorbidities that are present, that may be indicative as well to get some additional prenatal testing done. Um, Now, so what are some of these methods? Now, I know I mentioned blood tests, or not blood tests, I think I mentioned ultrasound earlier on, but that's not it. Most people are familiar with ultrasound, and we'll be talking about that. But in general, the prenatal diagnosis, they get divided into two categories, either that of being invasive or they are non-invasive, right? So now what's the difference between invasive versus non-invasive procedures? So when we're talking about an invasive procedure, we're talking about a medical procedure that invades the body, okay, or it enters the body. And this entering of the body usually, but not always, usually it's done by cutting or puncturing the skin or by inserting instruments into the body, right? So this is what invasive procedures are. Non-invasive procedures, on the other hand, they're absent of incision or cut or insertion of organs into the body. Okay, so this is the primary difference between the two. And again, in terms of risk factor, invasive procedures are always more risky. Anytime you're going to cut somebody open, there's risk of bleeding or damage to other parts of the body, other tissue of the body. Aside from that, there is always a risk of infection whenever you cut into the body. So in that sense, non-invasive procedures, they are less risk. They hold less risk factors. So let's talk about let's look into the first type of invasive diagnosis method, and this is called an amniocentesis. Okay, so an amniocentesis is usually performed in the second trimester of pregnancy, and it's what ends up happening is we take a needle, okay, a syringe and a needle, and use an ultrasound. This is an ultrasound transducer over here, and this allows the doctor to visualize. It allows him to see where the baby is and where the needle's going through. Because the aim is just to take out some of this fluid that the baby's swimming in. So think of this. This is the water bag. Okay, it's commonly known. Okay, as the laymen call it. You want to take out some of this water from this water bag, and that water, it's not called water, it's called amniotic fluid. This is the correct medical term. So the baby is swimming in amniotic fluid. This is what it's surrounded by. So this is what this amniocentesis, when you look at this term, centesis mean the withdrawal or removal of fluid from within a body part. So again, what are we trying to remove? The amnion. Okay, the amnion is the fluid, the amniotic fluid, so amniocentesis. Surgical removal of amnion. And they end up aspirating this amniotic fluid. And again, the amniotic fluid, it contains fetal cells. And again, you use this fluid to estimate, for example, you can look at bilirubin levels. Okay, this is one of the proteins that the liver produces. Okay, again, you look at this, to learn about. So bilirubin levels could be used to determine hemolytic diseases. Okay, also you can look at acetylcholinesterase levels. The cells, they could also be used for karyotyping, and so again, fetal cells, they get cultured for about 3 weeks, and then you can go about karyotyping. Could be done. So now, when do you want to do this amniocentesis? Amniocentesis, it's preferred to do about the 16th week of pregnancy, right? This is when the best time to do it is. Now, as far as risks go, so there's a risk of rupturing the membrane. Again, leaking of the amniotic fluid. There's also risk of the risk of RDS in newborns. So in terms of pregnancy loss, 1 in about 300 women, or perhaps 1 in 500 women, will miscarry. So there's a low risk. It's not very high, but again, still, it's a risk nevertheless. So, and again, this is decided by the mother along with her partner. Let's just keep it there, or husband. And of course, the doctor. The 3 of them can help. The ultimate decision will be that of the mother, and then the doctor gives the options and does all the explanation, and then hopefully, as a couple, the mother and the father of the child end up making the informed decision. So the next thing that we look at is what's called a chordocentesis. And this is similar to the amniocentesis in that it is ultrasound guided. So again, this is an ultrasound wand over here, and this gives visualization. So again, you go in with this is called the syringe and the needle. You go through, and then now you're removing fluid, okay, from the umbilical cord. Okay, so this chordocentesis, they can also, now this fluid is I shouldn't say fluid, but blood. You're taking out blood. So this procedure is also known as percutaneous umbilical blood sampling. Okay, this is what this PUBS means. Percutaneous umbilical blood sampling. So I explained the procedure to you, how it's done. Again, remember, this is ultrasound guided, and you're taking a needle and inserting it into the umbilical cord and aspirating or removing blood. This fetal blood sample then ends up being tested, and this ends up usually being done. This will get done after 18 weeks of pregnancy, and this could be used for chromosome analysis, in addition to biochemical diagnosis and biochemical as well as hematological diagnosis. Now, what's the risk factor? So, a little bit more risky, whereas in the case of an amniocentesis, we said about 1 in 300 maybe, or 1 in 500. For this one, it could be 2 in 100, okay? Chance of miscarriage. So again, it carries a significant amount of risk. That comes with it. All right, the next thing that we have over here is what's called a chorionic villus sampling, okay, or another term that they give is a CVS. This is the acronym for it, okay? CVS, chorionic villus sampling. All right, make sure you know that and you understand that. So again, this is the same thing in that in this procedure, what ends up happening is, again, you use an ultrasound, and now you're not inserting a needle, okay, but you're inserting this this catheter or tube, which goes and removes some. It retrieves a sample. So it's done through vaginally. Okay, so you have to go through, this is a speculum, the vaginal speculum. The gynecologist or the obstetrician will end up dilating the cervix, the vagina, and then this will end up, the catheter will be advanced. And then again, with the help of the ultrasound, the doctor knows where he is at, okay, which part, where this catheter is, and where he needs to move that catheter to, where he needs to advance it to obtain the sample. So essentially what you're doing is you're getting a collection of, you're just getting placenta, okay, you're getting fragments of that placental tissue. And again, the part is this chorionic villi. That's what you're after, okay, so hence the name chorionic villus sampling. So again, once you get the cells, then you can the cells could be studied for diagnosing of chromosome anomalies. So again, the CVS, it allows for molecular genetic tests to be carried out. Okay. The other thing is, you can do a karyotyping as well, direct karyotyping. So when you get the CVS sample, you can do this. We can have this cytotrophoblastic cells, and when you have these cytotrophoblastic cells, essentially they're just rapidly dividing cells, these cytotrophoblasts, and you can use that to do a direct karyotyping, and you get the results relatively fast, 24 hours, 48 hours time frame. So that's a good thing about it. Now, when could this be done? This chorionic villi sampling, the CVS, you can do this about 10 to 13 weeks of pregnancy. In terms of risk factor, it's about 1 in 100. All right. So again, it does come with its risk as well. Now we move on to cholecentesis. So this involves the aspiration of fluid from the extra embryonic colon, and it can be performed between the 6th and 12th week of gestation of pregnancy. Technically, it's not any more difficult to end up retrieving this than a CVS or an amniocentesis. So again, the advantage of this is that this could be done very early on. Okay, you can do this during early pregnancy. So examination of this coulombic fluid, it allows, you can accurately predict the fetal sex using what's called the FISH technique, or FISH is it stands for fluorescent in situ hybridization technique. Okay. So the fluorescent in situ hybridization technique, when you use this, you can determine the sex of the fetus, is male or female. Now, why would you want to know this? Well, because for example, if you know that you have the mother is a carrier or the father is a carrier of a certain gene which affects only one, if it affects a male, whereas perhaps it just affects a female, then at that point, again, the parents have a better understanding of what they're dealing with. So do they want to continue with the pregnancy, or do they not? Or are there any other options that are available to address that situation? So this could be one of the reasons why. And again, usually a lot of times you get this test done early on to terminate the pregnancy earlier. Okay, because again, this could be done between 6 to 12 weeks. So this could be done very early in the pregnancy. Aside from that, this can also detect a sickle cell gene. Other things, it hasn't been too good for. But so um, now the problem is that it's high risk. Okay, this is a high risk test. About 25% miscarriage, right? So out of 100 women that get this test done, 25 will end up having a miscarriage. Um, so yeah, that's the thing about this. Why do people still do this? Well, again, as I said, if you have a high predisposition to, if you're a carrier of a certain gene, you're having, and you want to have a child, a baby, then it may make sense for you to, to go and get this test done. So again, again, there's no right or there's no wrong answer. It just varies from person to person. Moving on to fetal tissue biopsy. So when you look over here, essentially, there's this, here's the ultrasound probe. And so, again, this is the mother's belly, and of course, this is the fetus over here. And this is a device that it gets inserted through, again, you make an incision, you go through, and you end up removing a small piece of tissue from the baby. Usually it ends up being removed from the baby's back or from the butt, or you call it the rump. So this procedure, it's used to detect hereditary conditions that can't be identified through the tests that we spoke about earlier, like the amniocentesis or the CVS. You can do this between 17 to 20 weeks of pregnancy, gestation. Gestation means pregnancy, by the way. So between 17 to 20 weeks of gestation, you can end up doing this test. Now, the main risk that's associated with fetal tissue biopsies is, again, a miscarriage. Okay, we're going to spontaneous miscarriage, and aside from that, infection, and even early delivery. Okay, so we call that preterm delivery. Aside from that, there's always a possibility. There's a risk of bleeding. Okay, the bleeding won't stop. Now, if you go to an experienced center, the incidence of a miscarriage, a fetal loss from the skin biopsy, it's reported to be less than 5%. So again, everything comes with a risk. Everything has its risk. All right, so those are all the the invasive procedures. Now let's talk about some of the non-invasive diagnostics. So one of the easiest and probably one of the most harmless things, and we'll talk about that, why I said probably harmless, would be an ultrasound. Okay, so this uses high frequency sound waves to produce a picture on a screen. And you can use this very early on in the pregnancy, 3 weeks, 4, 5, 6 weeks, you can use this very early, even probably possibly sooner than that. And again, a diagnostic ultrasonography, by the way, the acronym for that would be USG. Okay, USG. So, ultrasonography, you can use this to assess the size of the baby or the proportions, how big is the head. So take body measurements to come up with the fetal proportions. You can also use the ultrasound to determine the fetal sex, the fetal position, and also to visualize the placenta as well as the amount of amniotic fluid. So all this could be used for that. Now, neural tube defects could also be recognized by ultrasound, as well as possibly Down syndrome, body wall defects, growth disturbances, major limb abnormalities, or again, even major organ abnormalities. So all these could be initially detected. Okay, now I said initially because you have to do further testing to confirm it. Okay, so it's just an initial detection. Now, in terms of risk, so the general belief exists that the ultrasound doesn't pose any risk to the fetus or the mother. Now, nonetheless, ultrasound is a form of energy. Okay, and you know, we know that energy does have its effects in on biological tissues. Okay, so again, we call these bioeffects. So you know, how again, it's energy. So energy, it could be it could be the thermal effects, or it could be non-thermal effects, it could be mechanical effects of it. Uh, there's no concrete proof that it does that. However, we will say this, that you see, in terms of women who've had a lot of ultrasounds, they're when the fetus are born, sometimes the pregnancies are a little bit difficult. The deliveries may be a little bit complicated, or again, the fetus may be in a breech position. It's not in a normal position, meaning the head is not down towards the cervix. Um, so that may be, again, there's no direct correlation, but again, it has been noticed by many doctors. They haven't done any extensive research on it. Again, but let me just put it this way: um, is it harmful? Anything, when you do too much, there's always a possibility. Are ultrasounds harmful? For adults, most adults, probably not. It's very safe. However, if you abuse something, if you do way too much of it, then you're going to see some type of an effect. And in the case of a pregnant woman, it may not affect her directly, but it may somehow bother the fetus. Okay, so you do the pregnancies as needed. Don't try to do it. Some women, they're obsessed. Oh, I want to see my baby. I want to get an ultrasound. They have so many different type of ultrasounds also. So there's this 3D ultrasound, which came out about, maybe, I think, maybe 15 years ago. Now there's 3D color ultrasound. So literally, women will go, and again, they pay extra money to get a picture of their baby taken while they're inside of them. So yes, this is something that it's advancing, and again, it's turned into it's a business, and this is very common in the United States, very common, and I have no idea what the incidence is in Europe, or in Turkey for that matter, and other parts of the world, in the Middle East or Africa. But so yeah, this is 3D ultrasounds. That's what it does. There's also these color Dopplers, and again, this will give different type of images. Not as clear as a 3D ultrasound, but again, it's used to visualize. And a Doppler is just it's a form of an ultrasound also. And again, you can hear things as well. So if you want to hear a child's heartbeat, the infant's, not child, the fetuses, or the fetal heartbeat, then you can use this Doppler ultrasound just to listen to that. Okay, so again, they get used for even for normal people, for men who are not pregnant, or women that are not pregnant. If you want to determine if if there's a blood clot somewhere, or there's blood flowing, you can use a Doppler ultrasound as well, just to hear the blood passing through. Now, this is an ultrasound. This is an MRI. So what is an MRI? MRI is a magnetic resonance imaging. This is what it stands for. So essentially, it uses magnets, and to end up making, along with the help of a computer, to make a very detailed three-dimensional picture. And you can go through multiple layers to visualize organs and body parts. Now, MRI, you use an MRI usually after the 18th week of pregnancy. Okay, so after week 18 in pregnancy is when you would use an MRI. Now, most women that undergo a fetal MRI, they'll do this when some type of an abnormality is suspected on the ultrasound. Sometimes, as I said before, ultrasounds, they may have a hard time visualizing certain structures. For example, like the fetal brain is a little bit hard. So then at that point, you want to get a better look, then you go and you do the MRI. So MRI a risk-free method? Again, I will say that similar to that of an ultrasound. There's no radiation involved. In an ultrasound, there's no radiation involved either. You're using magnets over here, and in ultrasound, you're using sound waves. Don't get it done unless you really need it. Okay, so it's not a game. Do not abuse the technology. So next thing, you guys should know, what is this called? Who can name this? All right, so hopefully you guys know that this is a karyotype. Okay, karyotype. So the process of carrying out that is called karyotyping. So, yeah. So this karyotyping will get done usually prior to in vitro fertilization. So what ends up happening is at right around the third day, the DNA ends up being extracted, and then you end up testing, and then you get to see everything. And the embryos that come back testing normally, then they end up getting implanted into the mother. Okay, that's the purpose of karyotyping. All right, that's it. So this is why you do this before in vitro fertilization. So hopefully that makes sense. Other things that could be done is to look for the fetal cells in maternal circulation. So fetal cells in maternal circulation. All right, now this is non-invasive. All right, so let me remove this non-invasive part because let's just say it's a diagnosis method. Why? Because you have to get, if you're talking about getting blood, removing blood, that's an invasive procedure. Okay, so essentially what we're looking at are the fetal cells in maternal circulation. Now, what type of fetal cells do we find in maternal circulation? There's placental cells, there's white blood cells, and immature red blood cells, along with their nuclei that are present in the maternal blood. Okay. Usually this will enter the maternal, you can detect this about between 6 to 12 weeks, okay, in pregnancy. And yeah, so again, you can look at this pretty early on. Okay, it's about 6 weeks of pregnancy. And if you think about it, if you end up getting tested at this point compared to the other invasive procedures, a blood test is it has far less risk factors that are associated with it. Now, some of you might be a little bit confused, like, blood tests could be dangerous. Well, blood tests are generally generally speaking, they're relatively safe. Again, what are you doing when you're getting a blood test? You're breaking the skin and you're introducing an instrument into a vein to take blood out. So anytime you break skin, you risk the run of introducing an infection. So the risk of infection, even though it's very small, it's there. It's very real also. So what can you do with the fetal cells? Well, they're useful for detecting genetic diseases. How much, well, you're limited to as in the types of genetic disorders that you can look for. But again, still, this is a very good early test that could be done. Preliminary test. This is excellent option for that, especially because it's not as invasive as some of the other procedures that we discussed earlier on. The other limiting factor is, the amount of fetal cells are they're not that much, they're very small. So perhaps, 1 in 100,000 cells in the mother's blood is going to be that of fetal blood, the fetal cell. So again, there's not that many, but again, still it's a significant number. Next, we look at what are called the cell-free DNA, okay? Cell-free fetal DNA. So cffDNA, okay, and along with cell-free fetal RNA, again, this is either fetal DNA or fetal RNA that's circulating freely in the maternal bloodstream, and you end up getting this again through just a normal blood test from the mother. So you take a needle, put it into a vein in your arm, and remove the blood, and you can determine this at about 7 weeks of pregnancy. Okay, so again, you can get this done relatively earlier on. As the pregnancy progresses, then you're able to get a better amount, the higher. So in other words, the amount of cell-free fetal DNA ends up increasing as the pregnancy progresses. So this test, you can do to determine if the chance of a woman having a fetus with, for example, trisomy 21, Down syndrome, or trisomy 18 or trisomy 13, or even for again sex-linked disorders as well. So you can figure out what the chances are for a woman having any one of these disorders, these chromosomal anomalies. So as I mentioned, the advantage is that you can get this done very early on. In 7 weeks of pregnancy, you can get this done. All right. So again, is this invasive? Well, let's remove the non-invasive part. Why? Again, as I said, it is. You still have to get a blood test done for this. All right. Next, we're going to be looking at blood tests. Specifically, we're just going to be looking at more blood tests. So if you look over here, first, second, third trimester tests. All right. Essentially, you can do different tests during different parts of the pregnancy. So during the first trimester, ultrasound gets done. So along with an ultrasound, then you'll start looking at blood work. So there's different things you can look at, HCG levels. We're going to be talking about all these things in the next few slides moving forward. So let's get started with that. All right. So what are we looking at now in terms of biomarkers and blood tests? So one of the things that you look at is the maternal serum human chorionic gonadotropin. So in other words, this is the HCG, human chorionic gonadotropin. So if any one of you have ever had a pregnancy test where you have to urinate on a stick, or you take the stick and you dip it in the urine, that's what that is testing for. It's testing for human chorionic gonadotropin. Now, yes, you have it in urine, but also it's present in blood. So this is saying it's what? This is serum human chorionic, specifically from the mother. Maternal serum human chorionic gonadotropin. So this is one of the things that we can that you can look at. The other thing that we look at is another type of a protein that's called pregnancy-associated plasma protein, or just PAPPA. There is also human placental lactogen, or HPL. So these are some of the tests, again, that you look at, and their values, depending on what their values are, they mean different things. Now, the other thing that a mother will get tested for earlier on are the following things. Mother's going to get tested for her RH factor. Okay, usually if it's her first pregnancy, this is not an issue. Second pregnancy, this could be a problem, but it's very easy to address it if there is. Also, you want to check to make sure there is no HIV, that the mother is HIV negative. Now, every woman should get an HIV test done. Okay, every woman should get it done. Why? Because you don't know. And why do I say that? Let's put it this way. You don't know your partner's history, so you may trust them, and that's wonderful. But perhaps your partner had gone and gotten a blood test somewhere, or gotten an injection when they were sick, and if a contaminated needle were used, that would be a possibility for both, hepatitis, HIV, and other diseases as well. So, along with that, you get tested for rubella, as well as for syphilis. So hopefully all these come up negative, then there's no problem. If any one of these come up positive, the doctor will be prepared to treat it properly. And that doesn't mean that the baby's going to die or the baby will end up in any of these. No, that's not it. Mother, you can just still have a normal pregnancy and a healthy baby, even if you test positive for any one of these. All right, so we move on to beta HCG. Beta HCG can be used to calculate the precise age of the pregnancy, along with the help of an ultrasound. And this can also be indicative, depending on what the levels are. If you have high levels or low levels of a beta HCG. If maybe you have twins, maybe you have triplets or more. So this is another indicator for that. Also, it could indicate a possible miscarriage. All right. So if your body's not producing enough, that could be another sign for that. And it could also be indicative of disorders such as a molar pregnancy or even for an ectopic pregnancy. Now, beta HCGs, it could be either qualitative or quantitative. So what's the difference? A qualitative test just gives you a yes or no. Okay. So do you have HCG or not? In other words, are you pregnant or are you not pregnant? That's all that will say. Right? So when you're getting this urine test, that's what it's saying. Yes, you have it, or no, you don't, when you do the urine dipstick test. That would be qualitative. Now, quantitative, this actually measures the amount of HCG that you have in your blood. Okay, so if you're doing a quantitative beta HCG test, it's going to be measuring the amount of HCG in your blood. And again, this quantitative test will tell you how far along in the pregnancy you are. All right, so if you're unsure if you're 10 weeks, 11 weeks, 9 weeks or 13 weeks pregnant, then doctors there's a very good study, and they know that women at during certain with certain levels of HCG will be at certain points of time in their pregnancy. Okay, so this is how beta HCG ends up working. Next, we have this pregnancy-associated plasma protein, okay, or PAPPA, pregnancy-associated plasma protein. So concentrations early in the pregnancy of pregnancy-associated plasma protein, they've been associated with Down syndrome. They've also been associated with high rates of fetal loss. In addition to that, just poor fetal growth and even premature delivery. So again, this can tell you that there's some problems that are likely to occur if the women test come back up positive for this. Next, we look at alpha fetoprotein, or AFP. So during the first trimester, okay, this is produced in the yolk sac. Okay. So the AFP is produced in the yolk sac during the first trimester. In the second and third trimester, though, however, the fetal liver starts producing the AFP, the alpha fetoprotein. So maternal serum alpha fetoprotein, again, this ends up coming into the mother's blood. So the AFP levels, they start to increase from the 12th through the 32nd week of pregnancy. The test is most sensitive between 16 to 18 weeks. Now, if you see, notice over here, what it's telling you is depending on the different levels of AFP, it can tell you different things. Okay, so Down syndrome, again, if this is the level, and again, you would have during a specific time also. This could be indicative of a spina bifida or anencephaly. So different levels of AFP will be indicative of the possibility of these anomalies being present. Again, this is not 100%, but again, it's a good indicator. So if you get this a high AFP value, that doesn't mean that the child is going to be born with Down syndrome. No. That just says that the values are high and further tests need to be done. So then you do further testing. You look at an ultrasound, and you can do other blood tests as well along with it. So this is just a first line test that's done. So yeah, this AFP, again, this is a protein. It gets produced in the liver of that fetus, initially in the yolk sac, as I said before, and then later on, the fetal liver starts producing it. And as that baby develops some of that AFP, it passes through that placenta and then it enters that mother's bloodstream. This is where it becomes useful for testing, because now you can just take mom's blood. So yeah, let's just leave it at that. Let me just put it out. What I wanted to say is that AFP level, certain types of cancers, they also produce this protein AFP. So you may see a man getting this test done. So don't think that, oh, why is he having this? How can men be pregnant? No. Men do not get pregnant. But again, unfortunately, certain types of cancers, they end up producing this protein as well. So this is why you may see an older woman, for example, or a male being tested for alpha fetoprotein. All right, moving on to maternal serum estriol, okay, or UE3. So estriol is produced by the placenta from cholesterol, okay, in addition to progesterone. This is what ends up making the estriol, right? So estriol, it diffuses from the placenta into the mother's blood, where then you can measure it as, we call it it's called, this U stands for unconjugated. Okay, so it's unconjugated serum estriol, okay, or UE3. So in normal pregnancy, the UE3 levels, they increase from about usually between the 15th week till the time of delivery, they continue to rise. Okay, so they go up. So estriol, it ends up, so estriol, it promotes the uterus to grow. Okay, so again, it's gradually preparing the woman's body to give birth. When does the level start to go up? If you can see over here, usually, so again, if you come over here, so about 15 weeks are relatively high, but about the 8th week or 10th week, right around the 8th, I'll say about the 8th week of pregnancy, they will start to rise, okay? So yeah, go with that number. 8th week of pregnancy, they're going to start to rise. Estriol levels will start to rise at 8th week of pregnancy. And then again, they start to come to its peak levels right around the 15th. Again, they start to have high levels at about week 15, and they start to continue to rise throughout the pregnancy. So you can measure this not only in blood, in serum, but also in urine also. So that's the other part about it. Now, what can you detect with this? So if you look over here, Down syndrome. Okay, that's one of the things that could be detected by this. Aside from Down syndrome, there's also, you can detect neural tube defects as well. Here, let me fix this. There we go. So yeah, neural tube defects can also be detected by this test. Okay. The next thing that we want to look at is what's called dimeric inhibin. Okay. Now, dimeric inhibin A. Inhibin is a hormone that's secreted by granulosa cells that are found in ovarian follicles, and in addition to in men by Sertoli cells. So its physiological role is to suppress the secretion of follicle-stimulating hormone, okay, by the pituitary gland. Normally, now in pregnancy, a little bit different. In pregnancy, inhibin A is made by the placenta. Okay, generally, you end up getting this test done between 15 and 20 weeks, and you take this test, inhibin A, along with a few other things, and it ends up being part of a woman's complete blood work. Not complete, but it ends up being a part of the blood work. And what this will tell you is, one of the things, again, it will tell you is if the child has Down syndrome. So it's a very good indicator of Down syndrome, trisomy 21. Okay. In addition to that, it can also be indicative of trisomy 18 as well as trisomy 13. So this is what this test is done for. So we're gonna you'll understand this a little bit better. It's you don't just run this test by itself, but again, it's going to be part of a test. So you use this number along with other numbers also. So they all kind of confirm as to the series of different tests. They confirm there are high levels. They confirm each other. So again, this is where this, for example, this conjugate, or what we call this triple test would be. So again, this triple test, it measures alpha fetoprotein, human chorionic gonadotropin, as well as the UE3, right, levels. So when you take this, this gets done at about 15 to 18 weeks of pregnancy. Okay, this is the best time to do this. So again, this is going to end up confirming either trisomy 21 or again, Edwards syndrome, trisomy 18. Now, in cases where, so if you do have Down syndrome, what you end up seeing are low AFP and UE3 values. So the estriol values are going to be low, and the alpha fetoprotein values are going to be low, while the human chorionic gonadotropin, the HC values, they're elevated. So when you see this pattern, you can think, oh, it's probably Down syndrome. Okay, the chance of Down syndrome are high. So again, this triple test, when do you do this? Well, one of the indicators, again, if you have a high maternal age, let's just put it this way, in older women, you want to use this. So as maternal age increases, it necessitates for a triple test. In trisomy 18, you'll see low AFP, low estriol levels, as well as low human chorionic gonadotropin. Okay, so in trisomy 18, all levels are low. Everything that these three tests. Remember, each one of these, the alpha fetoprotein, the HCG, and as well as the estriol levels, they'll be low for trisomy 18. Trisomy 21, as I said before, you'll see a high HCG, while the AFP and the estriol are low. Right? So that's this triple test. Now, there's one more. The other test is this quadruple test, and this is where the inhibin comes in. So, okay, this dimeric inhibin A. So what is the quadruple test? Again, it's a triple test plus the inhibin A estimation. And once you get this number out, again, you end up having a better, so here, let me put it this way. This has over a 75% chance of correctly predicting Down syndrome, trisomy 21. Whereas the triple screen, it has about a 60% success rate in determining trisomy 21. All right, so you do a triple, all right, fine. This comes back high. Then you go and you do a quadruple as well to kind of confirm what the first test may have predicted. Okay, so this is the difference between it. So these are the different tests. So if you look over here, when we went back here, when you look at all these different screenings, essentially what did we say? We start off with ultrasound, right? If ultrasound comes back normal, mother's young, there's no complications. Then aside from just getting these biomarkers done, there's probably not a need to get everything else, all these other tests done. Probably not. Again, at different parts of the pregnancy, they may do this. So they'll probably do an HCG anyway. So then we looked at what these triple screen was, right? We looked at the different components, the alpha fetoprotein, the HCG, the estriol levels, and then we said the quadruple screen includes everything from the triple screen in addition to inhibin A. Aside from that, you just do a group B strep test as well, and then of course there's these genetic the ultrasounds as well. So along with the blood test, along with the triple ultrasound, you end up getting an ultrasound done as well. So now you compare both things. What does the ultrasound look like, and what does this blood test say? So if these things are giving like high indications of certain things, then you use the ultrasound to go and look at these structures to see, do you see some type of a neural tube defect? Or do you see any evidence of, now you start measuring what's the size of the hands, what's the size of the fingers, what's the size of the head. And then again, you can start to better confirm or understand what the likelihood is of these blood tests. All right. So with that said, all of this said, this is essentially all the prenatal diagnosis methods that are available. Now, the last part, okay, is counseling, genetic counseling. So instead of producing an entire lecture and going into all the details, both of these things, they go hand in hand. Okay, prenatal diagnosis and genetic counseling, they go together. You cannot separate. You really can't separate the two. You can, yes, but let me explain what this is in a nutshell. Okay, this is an organized. It's a structured appointment. Okay, you make with a nurse, a doctor, or again a genetic counselor at their office, and both the father and the mother of the fetus should be present. The baby should be present. So again, the couple should present together, and when they go to that genetic counselor, they may be going there because perhaps the mother realizes that she is a carrier of a certain gene, or perhaps the father is a carrier of a certain gene, or perhaps they are cousins. All right, and again, they have a specific condition in the family that tends to run. So this is why they're going to a genetic counselor. All right, we want to have a baby, and however, we have this, that, and that in our family. So at that point, the counselor, the nurse, the doctor, the professional that's there, they will go over the specific type of abnormality, or they may end up having both of the couples tested for that abnormality, and then they can discuss the occurrences of that. Now, they can tell them what all the test options that are available, and then they can decide to get what test that they want. Once the tests are done, then they will come back, and then they will review the test. Okay? So at that point, again, so some of the things that may allow for these tests to take place or not, first of all, would be availability. What is the availability of this test being done in the part of the world that you live in? That's one part to it, okay? Also, what type of a procedure does it involve? Some people may not want to get a certain type of a procedure done. Okay, if it's just a blood test, perhaps they'll be okay with it. But if it's something more invasive, they may not want to. So again, this gets explained as well. How is this testing done? Next thing is going to be the cost. How much does it cost? Not these genetic testing. They could be very expensive. They could cost thousands and thousands of dollars. I don't know about liras or euros, but again, they unfortunately, it's a big moneymaker in the United States. All right. I hope that it is not as bad in Europe, and I'm sure it's not abused in places like Turkey, the Middle East, and parts of Africa. So you go over, so the costs need to be understood as well. And then, of course, you want to talk about what is the ability of these diagnostic tests? What can they tell me, and what are the benefits of me getting this test done? And of course, you also want to talk about the possible risks of getting these tests done as well. Next, and again, you want to talk about, all right, fine, once you get these results, now we have the results, how do we manage this? How can we plan for these things? Okay, so this is what you want to look at, planning. What are the possible management planning options that are available? So in some cases, perhaps it's just, if they are pregnant, it's termination of that pregnancy. Right? So you may want to just end up having an abortion done, or that individual. Other times, they may decide to go about having in vitro fertilization. So remember we talked about in vitro fertilization. You can end up having this pre-implantation karyotyping that's done. So again, you end up retrieving the eggs, you look at the karyotype, everything looks good, there's no problems, then you can go ahead and insert the embryo into the mother. So that could be an option as well. Okay, so these are some of the things that genetic counseling will do. In other words, in a simple sentence, genetic counseling will allow the parents of not only the parents or potential parents to decide if they want to have a child and or continue with the pregnancy. Right? So this is what this will do. Genetic counseling will do. And again, if they do decide to keep the baby, then they're going to be better prepared, as we mentioned earlier on in the test, on how to deal with the baby that may have Down syndrome or Edwards or Patau syndrome, depending on which part of the world do they live. What type of resources are available for that individual? So these are all tools that can help the parents better cope and deal with having a child born with a certain disease or disorder. All right, so that is all for this lecture.